Everybody. Right, can I just check that everybody can hear and see? Can people see?
Yes,
Excellent.
thank you.
Yes, thank you.
Yes, thank you.
Fabulous. Thank you, everybody. Okay, then. So thank you so much for joining us this evening. It's great to have so many people here. I'm conscious that people might still arrive as we're working through. So just for some housekeeping, if I may, we're recording the session to enable us to share the recording and host it on Healthier Together following the event. If during the session, participants can keep their cameras and microphones off whilst they're not speaking, and please try not to take control of the slides as the speakers will move through the slides as they're presenting. We will share the slides and all of the resources from the session to those who've registered to attend, even if they've been unable to attend tonight. I will make a start now, but if colleagues could introduce themselves in the chat, the organisational group they represent and the geography in which they operate, that would be really, really helpful so we can understand the reach of this session. You'll appreciate that tonight's session is concerned with paediatric asthma and the management in local communities. My name is Louise Dauncey and I'm a Network Delivery Manager for the Child's Health and Wellbeing Network. My main role is around the delivery of the Children and Young Persons Transformation Programme here in the North East and North Cumbria. I'm here on behalf of the Child's Health and Wellbeing Network and the North East North Cumbria ICS Asthma Leadership Group, but I'm joined by a number of clinical colleagues from various parts of the health system who are advisors to our network, including Dr. Rampel and Dr. Hegop, who are our clinical advisors. Carol and Claire, two of our community asthma advisors, will lead the delivery of the main part of this session. Other colleagues and names and email addresses are included here, and obviously these slides will be shared so you can contact us following the session. I have a short slot at the beginning to frame the work and provide a little bit of background and context around the network and also the asthma programme. This is our suggested agenda. I'll do a very brief introduction, which will be followed by 3 sessions, which cover a general awareness session around asthma, sport and the impact of activity, and then we'll provide a brief introduction to our Beat Asthma Friendly Clubs accreditation. And then following this, hopefully we'll be able to take some time to have discussion and questions from the group. I won't go into detail as my time is short. The slide here just provides some local context and children and young persons population data and gives an indication of the size of our geography. The map on the right-hand side marks out the 13 local authority boundary areas that we cover, which includes 13 local authorities, 13 public health authorities, 8 acute trusts, 2 mental health trusts and 3 ambulance services, as well as numerous primary care networks. You'll appreciate within this, we also operate with the education system as they're a valuable part of our ICS. And within this, there's 1,400 plus schools and education settings across our huge geography. I won't spend too much time on this slide, but wanted to highlight the local levels of relative poverty and the challenges here in the North East and North Cumbria. As a professional working in this area, I'm sure you'll be well aware of the socioeconomic challenges locally and the impact of this on health and other outcomes for our children and young persons population. The takeaway here is that for the first time, the North East overtook London in relation to the rates of children living in relative poverty, and this sustained increase continues. In reality, this means that in an average class school size of 30, 11 of those children will be living in relative poverty. We also recognise the implications and impact of deprivation and poverty in terms of access to opportunities for activity and membership to clubs and groups, which is relevant in the case of our discussions tonight. The Child's Health and Wellbeing Network focuses on the needs of the children and young people and their families, and as such, children are at the heart of everything that we do. Our initial stakeholder engagement, as far back as 2019, took 1,000 points of contact, and we received from the stakeholders and families a range of priorities in areas of need that were pressing for them. And this is represented in the colourful wheel that we've described here. I won't go into detail, but for those colleagues who live and work in our local geography, none of these areas of priority will be a surprise, given the known levels of deprivation and the various challenges that we know of locally for our families. We've identified a series of cross-cutting enablers and themes, and you will see here that using all settings is highlighted as one of these themes. Within this, we've got a growing role in relation to the Children and Young Persons Transformation Agenda, in relation to additional needs and vulnerability, and also childhood illness. The Child Health and Wellbeing Network has an overriding vision which holds children at the centre of all we do. And our mission statement for children and young people, we outline our belief here that children should be given the opportunity to flourish, and that we can facilitate that as a network by supporting organisations to work together and systematically and cohesively to enable the sharing of good practice and driving improvement. Our network is growing and has a broad representation from across the system. We currently stand at over 1,900 members. And just to highlight, within our fold, we have an apprentice supported by Head Starters Middlesbrough, and we use his involvement within our professional engagement groups. The Child Health and Wellbeing Network itself has multiple strands of work, including youth voice, health inequalities, an ongoing programme of communications, engagement and training opportunities, delivery of the Children and Young Persons Transformation Programme, and the North East and North Cumbria Children and Young Persons Integration Centre. The Children and Young Persons Transformation Programme has three main aims, which relate predominantly to the integration of services, improving care quality and outcomes and experience for children and their families, and the more ready and active involvement of children and young people. Within this, there are 10 key areas of work relating to the NHS long-term plan. Long-term conditions and asthma are identified as a priority. The integration itself is a pilot project within the North East and North Cumbria and has a number of key components, one of which is the rollout of system-wide education-based intervention to improve community capacity and support the wider system to improve asthma management for our children and young people. The aims and objectives of the Children and Young Persons Programme and the Integration Centre closely align with the vision for the Child Health and Wellbeing Network. In the North East and North Cumbria, through the Integration Centre, we've been able to resource an asthma leadership group with a range of fellows and a workforce to deliver a range of activities across the system. We've got multiple projects that are underway, which are described in a bit more detail on the slide here, but we hope tonight to talk about community support and opportunities for clubs and groups. The slide describes some of the parallel bits of work ongoing in relation to asthma into the various parts of our complex health, social care and education system. There are links included on the slide, which will be shared, so participants can view these at their leisure. My email address is there on the slide for more information or for further discussion, and we will share these slides following this. So that's it from me regarding the network, but I would encourage you to look at our website and find out more about our various projects. If you aren't a member, please do sign up. We share updates on a weekly basis and provide opportunities for all sorts of engagement and discussion. The link here takes you to the sign up form. So without further ado, I'm going to hand to my colleague, Carol, Lead Community Asthma Advisor, and Claire, Community Asthma Advisor, who will take us through the next part of the session. Over to you. Thanks, Carol.
Thank you, Louise. The first section of our webinar tonight is on the importance of asthma and the impact on sport and activity. Next slide, please. Asthma is a common and chronic condition amongst children and young people. We know that the UK has got the highest admission rates in Europe, with approximately 26,000 children per year being admitted to hospital. This does not take into account emergency department attendances or GP appointments, which would number many more. Due to the number of admissions and frequency of exacerbation, there can be a significant impact on education and particularly on out-of-school activities and sport. Next slide, please. We know that the impact of asthma is that 1 in 11 children have asthma, and that means that on average there could be 3 children per class. In some areas of this country, it's significantly more, and in some areas it's significantly less. The figures here looking at asthma admissions, I've already mentioned, are approximately 26,000, but you can see there the recovery from the pandemic in 20 and 21 meant that the admission rate was significantly lower, but it is actually recovering to pre-pandemic numbers. Next slide, please. Asthma is a common lung condition that causes breathing difficulties. It can affect people of all ages and often starts in childhood, although it can also develop for the first time in adulthood. There is a misconception that asthma is not serious are only can be mild, and therefore there can be no risk. This is contrary and actually the opposite. The image on the right illustrates the bronchial tree, starting with a large upper airway, reducing in size and multiplying in number. Asthma occurs within the smallest tubes in the chest. Next slide, please. As you can see from the slide, there's a significant difference between a healthy airway on the left and the changes that occurs when asthma gets worse. On the left, you can see the diameter of that tube is particularly large, that there's healthy skin within the tubes, and it's pink and there's a large diameter to breathe through. In terms of an asthma airway, the muscles constrict and the diameter reduces with the bronchiole, and that due to inflammation. So you can see the furthest diagram on the right hand side shows asthma at its worst with a tight airway, inflammation and swelling. And also, in order to reduce inflammation, the natural body's response is to increase the amount of mucus that goes into that airway, and that's what causes an irritating cough with asthma. Next slide, please. So how do you know that a child has asthma? How is the diagnosis made? Trained professional will look at the history of the symptoms and combine this with tests and investigations, depending upon the age and the ability of the child and young person. It is based on a pattern over time of certain presenting signs and symptoms. Common symptoms are cough, wheeze and breathlessness in children, and also what's specific about asthma, it's variable within day to day and season, and can be very dependent upon what's happening at the time, particularly on asthma triggers. It could be essential that when a young person spends time in an out of hours activity, or in school particularly, that sports leaders and these activity leaders may spot that there's something different with that child. If the child already has a confirmed diagnosis of asthma, they may be spotting that the child has more symptoms, and therefore feel that that's important. And it is important to report that to a parent or a carer at the end of the session. The frequency that a child uses their rescue inhaler before, during and after an activity could indicate how well or not so well that the asthma is controlled. Next slide, please. So how is asthma treated? There are many different types of treatment for asthma, but there are some main groups. Relief inhalers are taken at the time that symptoms occur and become used in anticipation of symptoms or potential triggers. Therefore, some children you may find might come to an activity or a sport and say, I always take my relief inhaler before I do this activity. Preventative inhalers shouldn't be brought to activities. They are inhalers or medications that are used at home to prevent asthma getting worse and or to control the symptoms that children have. It's really important to know what treatment a child is on if they're in your care and they're taking part in an extra school activity, out of school activity, sport or activity. Rescue inhalers recently, until very recently, have always been blue, and it's been very clear which inhalers are which. However, things are changing, and it may be that children come with different sorts of inhalers in different colours and different types and tell you that this is their relief inhaler. Also, there's a new type of inhaler, which is a combination inhaler, and it consists of both relief and preventative in the same inhaler. At the moment, these are often white with a red end, but they may be different in the future. That's why it's important that we understand which inhalers do what, and the parents share that information with us before the child joins the activity. The way that a child takes their inhaler can be the difference in the response improvement made by that treatment. And information should be shared by parents and carers with the coaches and leaders of the correct technique that inhaler, for that particular inhaler. There are more severe or allergic types of asthma that require lots of additional forms of treatment. Some of these are oral medications, some of these are nasal sprays, and there are some children that have such severe asthma that they actually receive injections in secondary care settings and hospitals to control their severe and difficult asthma. Next slide, please. This is just to give everybody an indication of just how many different inhalers there are. And it wasn't so very long ago that there was two different colours to inhalers, and that's all. But as recent treatment has developed and improved, you can see here that we've got lots of different sorts of inhalers. The group on the top left is the inhaled corticosteroids. Most children who have asthma are on some form of inhaled steroid. You can see there's many different colours of those inhaled steroids on the left. On the right-hand side shows you the short-acting bronchodilators. These are the relief inhalers or the rescue inhalers. But there are also now a make of inhalers that are long-acting that children might take in combination with their inhaled steroids. The group of inhalers that I was talking about just a few moments ago was talking about combination inhalers. These are known as MART inhalers. They're maintenance and reliever in one inhaler. And you can see these children may come along with these types of inhalers to an outdoor sport or an indoor activity club and suggest to you that they may need to take these inhalers before the activity begins. And for the reason for that is if they open the airways and they help them to maintain the stamina that they need to complete the sport or activity. Next slide, please. It's really important that the correct technique is done with each inhaler, but it's also very important that the right spacer is identified for the right treatment. Younger children usually have masks on their spacer, and you can see that there's a number of spacers there that have masks attached. Young children take their spacer by the mask going over the face for about 20 seconds per dose. But it's really important that when the inhaler is used, it's shaken before and after that each dose is delivered. Older children don't need a mask and use the valve to breathe 5 slow breaths, as in the spacer on the far right-hand side of the image. All families and children have had the correct training, or should have had the correct training, in the correct use of their inhalers and their spacer by their practice nurse or by their specialist nurse. And this is rechecked every time a child goes to an appointment or has an annual review. At the bottom, you can see there's a link there. There's a regional website called Beat Asthma, which has many useful resources for families, for sports centres, for anyone really wanting to know any information about asthma. And this has lots of information for young people, for management of asthma, for acute exacerbations, and really holds lots of interesting resources. And it's a link there that can be very useful to anybody interested in the care of children with asthma. Next slide, please. So what are we aiming to achieve with asthma management? Well, we know that asthma can be managed well for the majority of children and young people. The aim of treatment is that children and young people take part in activities and have a good quality of life. So as physicians, the aim really is to ensure that we reduce weekly symptoms, therefore reducing the need for oral steroids, that children take their treatment, and you may be quite surprised to know that round about 50% of children don't take their inhalers at the right time and with the right technique. We strongly encourage a good technique and reinforce that technique every time a child comes to clinic, because it's really important to ensure that the inhaled medication is actually reaching the lungs. And we also ensure that the child and family are educated well to give them empowerment on self-medication and self-monitoring. In order for a child to understand when they should take their inhalers, they need to have adequate information on their symptoms and when symptoms are getting worse. Knowing what good control is will prompt early recognition of an intervention needed. Self-management by the family and young person is essential. However, guidance during activities and out-of-school activities particularly can reinforce key messages and support the child and young person. Some young children, particularly when they're excited to join in their activity, actually forget to take their inhaler before they start their activity, or don't recognise that they need to take their inhaler during the activity. And it can be that the people supporting them around their activity can prompt them to go and take the inhaler and also encourage them to take it correctly. Next slide, please. So this is one of the resources that is hosted on the Beat Asthma website, and it's about how to recognise an asthma attack. And I think in terms of leaders and sports coaches, this is what worries everybody. Would I recognise when a child was getting more unwell in my care, and would I know what to do? How would I recognise this? The recognition of increasing symptoms exacerbation, or known as an attack, is really important, as the earlier the signs are detected, the better the outcome. There are some differences from child to child about how they cope with their asthma symptoms, in that some children and young people tolerate their symptoms with little indication or signs. For these children, it's really important to have an open discussion with parents or carers, and that a plan is made so that the subtle differences in their asthma can be notified. For some children and young people joining in groups, there's reluctance to admit that they've got symptoms in case of being withdrawn from a game or activity, or not getting included in the team in case they get worse. So some of the symptoms are highlighted here. Children breathe hard and fast. There might be a wheezing noise coming from the chest. It's typically a high-pitched whistling noise on breathing in and out, but more commonly on breathing out. Children often have a cough. It's not necessary that they cough and wheeze. Some children just have a cough. This cough is particularly worse at night, and often children attending school seem tired when their asthma has been exacerbated. A lot of children report that they feel breathless or that their chest feels very tight. And in younger children, they complain of tummy pains. What is obvious in an exacerbation of asthma is that there can be an increased use of a blue inhaler. And overuse of blue inhaler is a significant indication that asthma is not well controlled. And what's more important about this is to recognise when the blue inhaler is not improving symptoms. Next slide, please. So once symptoms of asthma have been recognised, what can we do about it? What can you see? So on the left-hand side of this algorithm, it talks about mild and moderate symptoms. Now, that doesn't mean to say that that is a risk. That isn't a risk, it is a risk. But these symptoms are quite common in asthma. We've just discussed children who cough, have a wheeze, get a little bit short of breath, and complain of chest tightness. And sometimes children exhibit the signs of asthma by not being as active as they usually are, or acting in a quiet manner. On the right-hand side is the concerning side of the algorithm. Children, and younger children particularly, who are unwell with their asthma, can have a rapid breathing rate, and it's a shallow breathing rate. You might see that they're working hard to breathe. The best assessment of a child who is struggling to breathe is also to try and get the child to talk to you. The number of words that a child can say reflects how severe their asthma is. So if a child can only answer in one single word, it's getting severe. There may be a colour change on the skin or on the lips, but this is quite a late phase, and the child has struggled for a considerable length of time before the colour of their skin changes. It might be that the child gets distressed or upset or a little bit confused, and this is a sign of severe and difficult asthma. Next slide, please. The actions for both start with the same point. Be calm and reassuring. Children and young people tell us that they can hear somebody speaking calmly to them and telling them that everything is going to be okay. They feel reassured and they can gain some control of their breathing, which is quite difficult when your asthma is severe. In terms of the algorithm on the left-hand side, a child with mild to moderate symptoms, we would encourage that child to sit down and loosen any tight clothing if there was any. We administer 2 doses of blue inhaler through a spacer, 1 dose at a time, and make sure that the inhaler is shaken before each dose. And that can keep going every 10 minutes until they've had a dose of up to a total of 6 doses. If a child has the combined type of inhaler, we encourage that they take 1 dose and wait 10 minutes and see if there's any effect from that dose. And after that, if there isn't an effect, there can be an extra 4 doses given. During this time, we're going to encourage the child to try and breathe at a normal breathing rate. On the right-hand side of the algorithm, we're talking about a child who's exhibiting signs of really quite severe and difficult asthma. The very first thing is that a colleague will be asked to dial 999 and contact the parent or guardian made. Be calm and confident and reassuring, and we start to administer the child's rescue inhaler every 30 seconds through a spacer, shaken before each dose until the ambulance arrives. If a child is in a severe and serious condition where they're looking like they're going to lose consciousness or they can't maintain an upright position, then you would follow the routine emergency first aid procedures. Next slide, please. So on the mild to moderate side, we're asking, has the child responded to the treatment we've given? If that is the case and the child looks like they've recovered and they're saying they feel better, we would encourage that the child sit for at least 15 to 20 minutes, but be in a position where they can be observed. In times where there has been difficult situations with children in settings where they have been left unassisted following their inhaler and there has been a deterioration, it's been a recommendation that children should always be observed following a blue inhaler or their rescue inhaler. They can be allowed to rejoin the session. If they're feeling well enough to join back in, that's absolutely fine, but possibly to keep an eye on them for the rest of the session to make sure they're managing. At the end of the session, the parent or the carer should be informed that they've needed some treatment during their sporting activity. And the recommendations are, if symptoms return within 4 hours of that dose, it can be repeated, but the parent or carer should be asked to collect that child. And that could be a school setting, a summer holidays camp, or a longer session of sport or activity. Next slide, please. So moving on to session 2, talking about the benefits of exercise, the impact of asthma on exercise, how to recognise that asthma is worse, how to manage an asthma attack, and improving the environment for asthma. Next slide, please. We know that the government recommendations for healthy children in this country is that across the course of the week, children do 60 minutes of exercise per day. And we know that this is quite a task for some families and children to maintain. But we know that physical activity builds confidence and social skills, develops coordination, improves concentration and learning, strengthens muscles and bones, improves health and fitness, maintains healthy weight, improves sleep, and basically makes you feel really good. Next slide, please. So what are the statistics for asthma in sport then? Are we seeing lots of asthma in sport? And this is a question I'm often asked. A high proportion of top athletes suffer with sport-induced asthma, and it's more common in the higher tiers of professional sports. Around 90% of asthma sufferers at some point have told us that during physical activity, they get symptoms of their asthma. Some children and young people experience symptoms and don't have a diagnosis. And this is why it's essential, if we see symptoms in children who aren't diagnosed with asthma, that also communication is made with parents and carers at the end of that session. We know that children and young people with asthma don't try and avoid activity. They actually like joining in activity, and they have equal levels of activity. They try to join in equal levels of activity compared to healthy children. But we know that healthy children in this country, there's only about 50% achieve the national targets. Children and young people with the more severe type of asthma and are admitted often to hospital are much less likely to be active and want to join in sessions. Awareness and recognition of these children is essential to encourage their attendance and to manage symptoms during sport. In some elite sports, asthma can be present in about 3 out of 10 athletes, and particularly in high professional football. Next slide, please. So although beneficial for health and well-being, most children do not achieve recommended levels of physical activity, and the evidence for children with asthma is mixed, and it depends upon symptom severity and frequency. Asthma can cause acute bronchospasm in the airways, and combined with obesity, it can increase the number of asthma symptoms and frequency. This might be children that are fearful of joining in when they have asthma. They can be reluctant to participate, and this can be down to embarrassment about not keeping up or making onto a team. And we often speak to children and people who say they really don't want to use their blue inhaler in front of their teammates or friends. Next slide, please. So why does exercise cause asthma symptoms? Well, in the healthy airway, and we've already seen the slide about a normal airway, which is on the left side of the image here, we know that during exercise, children and young people take much bigger breaths and the airways relax. And the contrary to that, asthma airways during exercise, the airways can narrow, squeeze tight, and dry out during or after exercise. So there are some children who, although they don't show any signs of difficulty with their asthma when they're actually performing the activity, it can happen 15 to 20 minutes after they stop. So it's important to recognise that changes are happening here. At this point, I'm going to hand you over to my colleague Claire, who's going to talk about triggers for asthma and how we can manage those triggers. Thank you, Claire. Next slide, please.
Thank you, Carol. So we're now going to look at some of the asthma symptoms and the triggers that can cause, and there's many different triggers. We know that some are very common, and this slide shows some examples of them. Not all children will be triggered by some of the examples shown here. However, some are very common triggers. What we need to remember is that in sports and activities clubs, there may be multiple triggers. So, for example, playing on a football pitch could affect a child or young person with asthma during the summer, but also during the winter, particularly in the outdoors and the cold. We also need to consider some sports will be affected. Some indoor sports will be affected by dust mite and maybe some gym mite. There's lots and lots of triggers. And even if you can see there, emotions, laughing, anxiety and stress can even be a trigger for asthma, along with pollen, mold, and obviously chemicals that may be used within the sports or activities for cleaning of equipment. And obviously temperature change, particularly key at this time of year with the cold weather. Next slide, please. This is the calendar that a single calendar that was developed as part of the Asthma Friendly Schools pilot. It was a request from the schools. It can either be used as a poster, or what we have done is we've sort of seasoned it. So winter triggers, spring triggers, autumn triggers and summer triggers. The calendar demonstrates how the environmental factors can have a significant impact on the management of a child's asthma. This can be sent to parents, or schools were going to use the winter triggers and send it out as a bulletin or as a reminder. Just be aware in the winter that these are some of the triggers that might impact on a child or young person who has asthma. Or, like I say, it could be used as a poster and displayed within your club. Next slide, please. The management of asthma during activities and sports. This shows some of the key points that we need to consider when children and young people are undertaking sport. So national standards is that every child or young person has a management plan, and we'll show you what a management plan, a personalised asthma action plan looks like later in the presentation. As a sports club, you would need to be aware of a child or young person has asthma and make sure that you're keeping a record of it. Clear communication with parents and carers and leaders and coaches would be encouraged to have that, so that maybe if the child was having an off day or hadn't been well, that the coach or the leader was aware of that, so that they incorporated that into the session, so that they were aware to maybe monitor the child a little bit more or watch them. Have an awareness of what's actually in that child's personalised asthma action plan. It is a personalised asthma action plan, so it's written individually for that child. It will name their key triggers and what may cause them to have an attack. So be aware of that, so that you can watch out for some of those during the activity or the club session. Make adaptations maybe to the exercises if needed. What we want to do is to be able to encourage all children to participate and to be able to achieve in that spot. So it may be that, if the child is a little bit wheezy or hasn't been well, that you might need to change the session a little bit and put some adaptations in place. Make sure, particularly with these children, that there is a good warm up and cool down of exercises, and encourage the young person. I know Carol's already said that sometimes they don't like taking their inhaler in front of the friend, but encourage them that it is okay to take their inhaler, and observe that they're maybe taking it the correct way if you're able to, or provide them with a space where they could maybe go and take it out the way of everybody. And if they've got the spacer, obviously what we like is that they use the spacer, so they may feel more comfortable taking it in a private area if possible. Obviously that may be more difficult on a cricket or a rugby or a football pitch. And coaches and leaders, liaise with the parents, make sure that, if you feel that the child has used their inhaler more and you've observed it, just make sure that you do have a little chat with the parent carer at the end of that session and just make them aware of that, and then they'll be more aware for when the child or young person goes home. Next slide, please. This is an example of one of the asthma management plans. So you can see there that it shows common triggers and what my triggers are. It's also got the doctor's name, maybe who the asthma nurse is, and that would obviously help if they're under a specialist nurse. It would make you aware who the nurse is. And there may be some additional comments of things to look out for there. If a child has a purple plan, asthma management plan, that means that they have more severe asthma. So you would certainly need to be aware of that, and obviously contact for medical advice or support if that child became unwell. What we've recommended is that it's important that parents share this information with the leaders and the coaches to ensure that the child's specific needs, because like we've said, not every child is affected by every trigger. Some are more common than others, but just to be aware of what that individual child's triggers are so that you can look out for them during your sessions or activities. Next slide, please. So as you can see, this plan has a green, an amber and a red zone. So our green zone is if the child is good and if they're well controlled. This is what the child will look like. The breathing will be good. They won't have a cough or a wheeze. They won't be missing any school or activity. Looking at our amber, this is our warning. So they might be starting to have some of the symptoms that Carol's already discussed: a cough, a wheeze, complaining of a tightness in the chest. We know that young children often complain of a tummy ache. They wouldn't necessarily say that they've got a tight chest. They might hold the tummy and say the tummy's hurting. At this point, you would ask them to try and use their inhaler and sit them down, give them some reassurance, and obviously observe them. And like Carol said, we can give up to 6 puffs before we would move into our red zone. In our red zone, that's our severe. This is when we need to take some action. So this child would be finding it difficult. They would be quite breathless, and they wouldn't be able to talk in sentences. And this is when we need to get some help and call 999 and obviously contact the parent. Next slide, please. This is an example of the Asthma and Lung UK asthma plan. We're just trying to show you some examples because children may not all bring the same plan in. Some children actually now, some practices, GP practices, are actually texting the plans through. So the child may actually have the plan on the phone if they're an older child, or the parent if they're a younger child. Again, it's similar. I'm having an asthma attack. This is what to do. And all children would usually have an asthma review within a year, yearly. It's a recommendation. So if you have got a child or young person in your activity that you feel is coughing a lot or taking a lot of inhaler, it may be worth having those conversations with the parent carer and just saying, have they had a recent review? Has the medication been changed? Has anything changed? Or just encouraging them to make contact with the practice nurse or the specialist nurse. Next slide, please. Our next session is going to look at the Beat Asthma Sports Clubs accreditation and look at the resources that are available and the support, along with the training, the free training that is also available. On this slide, obviously you're going to receive the slides at the end of the presentation, is a link to the sports and clubs activity accreditation, and it goes through step by step how you can register and become interested, or what you may need to include if you would like to become accredited, and we'll pop those details in the chat for you. Next slide, please. So I know Carol's already discussed it. So our work has come about because of the National Bundle of Care for Children and Young People, asthma, and the main aim is to control asthma symptoms, reduce the risk of asthma attacks, avoid preventable harm, and to improve the quality of life of young people who have asthma. And that the link is there if anybody would like any further details around that. Next slide, please. This is an example of the bundle and the stages that are within it. So it's a whole system approach. What we would be looking at within, so this all relates to primary care, secondary care, and our tertiary care, which is our specialist centre who deal with children and young people with asthma. But with sports, if we're looking at sports, a whole system approach. So we're looking at that everybody's involved, including the coaches, the leaders, the parents, the carers, and the children and young people. It's a whole system approach within the activity. So everybody's aware of asthma and how to deal and improve the young people's opportunities to be involved in asthma. We're looking at leadership. So within the leadership, we want maybe a named champion or a lead for asthma within the club. This would be that you have a register or you keep a record, some medical evidence of the children and young people who have asthma. You might have examples of the personalised asthma action plans. And this would be your named person who'd be able to contact the parents in the case of an emergency if the child became unwell. And we know that some clubs, it's very different. We know some clubs and activities may have 1 or 2 leaders, others may have 5 or 6 leaders or even more. But it's having a named champion or a lead and who takes that responsibility. Because obviously you may have new children that join your club who have medical needs and asthma, or you may have children who are in your club who are then diagnosed with asthma. It's an awareness of the environmental impacts. So often what we're looking at that it's not a smoke-free site, or that you don't, and vaping's not allowed. We might look at car engines not being running near the activity, not sending children and young people out onto freshly cut grass. So looking at some of the environmental impacts that might affect the child or young person and trigger their asthma. Early and accurate diagnosis, being aware of the signs of asthma, which obviously Carol has discussed in detail at the beginning of the presentation. Also looking at communication with parents. So like we said, be encouraged to talk to parents if you're concerned that the child's using the rescue inhaler a little bit more, or that they are maybe coughing. Effective preventable medicine. So this is about the child and person having the PAP, having the regular asthma reviews. And just as a coach or leader, you're aware of those important factors that might trigger that child and make them unwell. And as Carol's already discussed, it's being able to recognise those key triggers or that a child is unwell. And we know that some activities may have a few children in, and some may have a lot more. So it's having an awareness and being aware of those children and young people and keeping a close eye on them so that they can enjoy and participate in the sport like their friends. Next slide, please. So we're going to move on to the sports and activity accreditation. So this is open to any clubs within. You can see our map there, the North East and North Cumbria. We cover a wide area right from Redcar up to Berwick and across to Carlisle. So it's available to any sports or activity clubs, brownies, guides. It may be football, cricket, rugby, swimming, gymnastics, available to all clubs within this area. Next slide, please. We felt that it was important with the schools policy, what we looked at, that the schools had an asthma policy in place. What we've recommended for clubs is that they have an inclusion statement. This is to endeavour that not to ensure that all children with asthma feel that their individual needs are being met. So the child and young person, we know that if they have asthma, they can actually benefit from for being part of a sports or activity club. Children and young people need to feel included and able to participate in sport and activities, and they also need to be able to have access to their rescue inhalers. And what we recommend is that they should be bringing them to the sessions, and they should be in a box, possibly labelled with the name. Or some of our older children may not still have the boxes, but they will carry their inhaler themselves like they would in school. But we know it's beneficial for children and young people to be involved in sports. Having open communication with parents and carers regarding the child, and that statement is included in our accreditation. Next slide, please. Moving on to the Beat Asthma Friendly Sports and Activities Accreditation. It's an 8-step process. It's probably some of the things that you have already got in place. What we're looking for is evidence of an inclusion statement. We've already said we have got that inclusion statement there that you can just print out, and it's available to use within your pack. Having a named asthma champion or lead within your sport or activity. Having some sort of asthma register or medical register with emergency contacts, which you may already have. Looking at medication, we're looking at that the children and young people have got access to their own medication. It may have the pharmacy label on, it may not. And also they may have a spacer, or they may have a dry powder dose, because powders have lots of different inhalers. So looking at the medication and that they've got ease of access to it. Personalised asthma action plans, we know that the schools have struggled getting copies from every parent. So what we're looking at is that you've made a request from the parent or the young person to have a copy of the plan so that you are aware of what their triggers are. Looking at some examples of pollution, we've already talked about smoke-free site, not having car engines running near the sports, maybe not sending the children straight out onto the cut grass. If it's an indoor sport, we might not have lots of smellies, diffusers, candles, or anything that might trigger. And looking at communication, number 7, that's number 7. So communication with parents and carers, how do you communicate with them? Do you communicate by text messages? Do you invite them in for sessions to observe? And you know, involving the parents, how you involve the parent carers in to maybe watch the dance show, watch the gymnastics show, come and see how the child is doing and what they're up to, which is really, really important. And training, we're gonna discuss the training briefly, but the training is available, it's free, and what we're hoping is that 75% of staff who have contact with children will undertake the free training session. Next slide, please. This is just an example of the checklist, and it is a tick list until it comes to pollution or the sharing with parent and carers, and it would just be a few bullet points that we would want documented to achieve the accreditation, and obviously there's the link for the training. So like I say, it would be a tick and the date that that's been achieved. Next slide, please. This is an example of our training. Tier 1 is a 45-minute session. It's online. It's multiple choice questions just to check an individual's knowledge and understanding, and it is free. This training is aimed at social care staff. It's aimed at sports and activity clubs, education staff. And that would be the training that we would expect 75% of staff to complete. And like I say, it takes 45 minutes and it is free online training. And this would need to be updated every 2 years. Next slide, please. This is an example of a poster that's been developed that could be used within your club or activity you may want to put up, or maybe discuss with parents, send out to parent carers. And the next slide, please. Is another example of a poster that you may want to use or send out to parents about the importance of exercise and asthma and the benefits for children. Thank you very much. That's our last slide. Thank you, Louise. That's just some references we've used.
Great. Thank you very much, Claire and Carol, for your time tonight and for presenting that for us, and also for the rest of the group for your attendance. Now, this is an opportunity for the group, for participants to raise any questions or concerns or comments, and we will endeavour to answer them. We're a team here tonight. We've got ourselves and then Dr. Ramphel and I think Ahmed Hegab as well. So if anyone's got anything that they'd like to ask or comment, the floor is yours for the last 5 or 10 minutes of the session. Is there anything from anybody? I'm just wondering if we've... Oh, Inga.
Hello. I work for the STARS team. There's a couple of our staff on here this evening. We run social groups for visually and hearing impaired children. And we also have residentials as well that we run, and we've got a residential booked for July this year. Now, we've collated all of the medical information from the children and the families already, and quite a few of them have asthma and need inhalers. Are we legally allowed to give the preventative inhaler on the morning and or the evening, whatever plan is for the child? Are we okay doing that without training on how to administer it? Will the online training be enough for us to know what we're doing?
Yes, it does offer inhaler technique, but also the link that I've put on the slides, the Beat Asthma website, also has videos for every inhaler on how to use it properly. I think that the legal requirement, that's sort of an area that's a little bit, we have to be careful how we respond to this. I think by fact that the parent is sending the child with you in loco parentis would mean that they're offering that consent for you to deliver that treatment. There will have been education and training for that parent on how to use that inhaler properly. So probably I would suggest that as part of the the preamble to you going away, that there is 5-10 minutes spent with that parent saying, just show me how you've been shown how to do this inhaler for this particular child. Because most of the time it's the same technique for most children, but there are adaptations made for particular situations. So it would be good to know if that child had it that particular way, because we know there's some diversion from the norm for a few children. But I think from that point of view, the legal perspective is there's probably been consent signed for the tripson for any medication or first aid to be administered as appropriate. So I think you would be covered on from that point of view. The training itself can either be on the 45-minute training or the website videos, which are excellent.
Right. Okay? Oh, that's brilliant. Thank you very much.
Question. Thank you.
Thank you.
Thanks, Inga. Just to sort of support what Carol said there, I've just put the link. There's a poster. There's a link in the chat, which is a poster with a series of QR codes. So if you scan the QR code for the relevant inhaler that you're particularly interested in, you'll get taken to the Beat Asthma page, which has a video, which it's advice and guidance, and it's meant for public consumption. So again, I can't add to the legality question, but essentially in terms of advice and guidance about how to use them, that's there.
Thank you.
Thank you. Is there anything else from anybody? I'll just have a quick flick through the chat to make sure that we haven't missed any questions. Okay. No questions. People have introduced themselves, which is helpful. Dr. Ramphel, I don't know if you're still there. There's a comment there that you've identified about a consent form and for how schools might have emergency treatment or painkillers. I don't know if you want to bring that comment forward.
So similar to what Carol is saying is that generally, if they have agreed to send the child with you, then they would have given you implied consent of whatever medication needs to be given is to be given. But what schools tend to do is they have a section that says that any emergency medication or any medication that needs to be given, you're giving consent for those to be administered. So that might be something that you want to include on your consent form.
Thank you.
Great, thank you.
From a point of view of coaching sport, as well as being a respiratory nurse, I do coach some sport outside. We do find that there is misconceptions about asthma and management in terms of families think that they don't need to send their inhaler. They've been okay today, so I don't need to send their inhaler, or they're not quite sure what they should be doing about that inhaler. So in terms of, do I send it in? Do I send it in label? Do I not send it in? And I think, that we've had a significant number of children within our sport that now we've identified as coaches that they haven't been very well. And there's a bit of surprise from the parents afterwards when we say, he's been really wheezy, and they say, well, yeah, he does get wheezy, he's got asthma, but actually that is a symptom of asthma. And children shouldn't wheeze if they have asthma if they're well controlled. So there's an acceptance generally that you should have symptoms if you have asthma. But the goal and objective is that children shouldn't have symptoms if they have asthma. They should be well controlled. So from that perspective, there's a lot to learn about sports and, management of asthma, as well as in secondary care, we learn the same lessons about children all of the time, and the way each family dynamics is different.
Okay, thanks, Carol. Okay, No, I can't see any hands from the rest of the groups, but I think it's just worth sort of in terms of a closing remark or comment in regards to the presentation. I think it's really valuable to see that how this programme we're trying to provide the support into the community to be able to kind of better manage asthma into the community. And obviously recognising that we talk about sports, but actually this is kind of collective, not just necessarily about sports, and includes those wider kind of community and social groups. Because often, we need to be in places or provide this education into places where lots of children are. So we've obviously worked with schools and we've done the programme with schools. So this is kind of our natural next step. So all of the resources that Claire's described today from our accreditation scheme are now available on the website. And obviously, I think the link is in the chat, or we'll just check if it's not. But either which way, it's going to be in the slides as well. So you'll be able to get those. Now, all individuals registered will receive a direct video link to be able to watch this recording back. Obviously, to be able to get the information again from the asthma management slides at the beginning, as well as obviously the availability of all the links. So unless there's anything else from anybody, I think that brings our sort of session to a close. So all that's left for me is to say thank you very much for people for taking the time to come tonight. Appreciate it if it's out of hours and what have you. And also to Carol, Claire and the rest of the Asthma Leadership Group here today for providing support and access. So that's it. Our email addresses are on the slides, and we would love to hear from anybody if people have further feedback or follow-up. Thank you very much, everybody.
Thank you, everyone. Thank you, everybody.
Thank you. Bye-bye.
Thank you. Bye.
Bye.
Bye, Dr. Hegab. Stop recording. Right. Stop recording. Stop.